Before we set out to master the art of surgical knot tying, it is important to first ask the question, does proper knot tying technique matter? To answer this question, let's first consider a related but more concrete one. Can insecure knots negatively impact patient outcomes? The answer is most certainly, and the consequences can be catastrophic. Let's consider a case on the extreme end of the spectrum. In 2004, forensic pathologist Judy Melinek and her team reported on a post-mortem analysis of a patient who had undergone a carotid endarterectomy. The patient initially did well after surgery until 18 hours post-op when he was sleeping, woke up, became agitated, attempted to get out of bed, and was later noted to have bleeding from his cervical incision. He was rushed back to the operating room but died intraoperatively from massive exsanguination. On the post-mortem analysis, 2 untied ends of a suture were identified, one straight and the other tightly coiled, consistent with a single-post half-hitch knot that had slipped completely apart. Melinek reviewed the New York City Chief Medical Examiner's records and identified additional cases of fatal exsanguinations due to knots unraveling. The natural follow-up question is then, can proper knot tying technique significantly improve knot security to prevent complications from knot slippage? The answer here, again, is a resounding yes. There is a plethora of surgical literature to support this, but rather than citing studies, I will provide you with a demonstration of this principle. Shown here is the setup for our brief experiment. On the left, you can see a manual force test stand, which we will use to test the security of the knots we tie. On the right is a holding apparatus for pairs of brass rings that we will tie together. We will tie 2 different knots. Both of these knots will be tied using the same suture material, 2O silk, and both will be tied with 5 throws. Notice that for this first knot, every time one strand is wrapped about the other, which we will call a throw, the throw is pushed down by the right hand. The left hand simply passively holds the suture up. In contrast, for the second knot, the first 2 throws are pushed down by the right hand, but then the left and right hand take turns pushing down the subsequent throws. Once we are done tying, we cut the tails of both knots, extract the first of our brass ring pairings, and load it onto the force stand. Once the hooks of the force stand have fully engaged the brass rings, they are pulled apart at a fixed rate with the assistance of a metronome, and we can see the force with which the knot resists being pulled apart displayed on the monitor, which is in newtons, a unit of force. Note that the force generated by this first knot never exceeds 3.1 newtons. For comparison, if a seromuscular bite of colon is taken and the suture is pulled, the colon will not start to tear until 25 newtons. Also note that the knot unravels rather than breaks, and the lower brass ring simply falls away when the knot has come completely undone, while the upper brass ring is largely unaffected. Next, we load the second of our brass ring pairings onto the force stand. This knot quickly exceeds 3 newtons and continues to climb to over 50 newtons. Note that in contrast to the prior knot, this knot fails by breaking, which can be appreciated both by the sound of the knot breaking and also the recoil of the brass rings away from one another as the knot breaks. The recoil causes the upper brass ring to bounce up and off the hook that is holding it. Since insecure knots can have potentially devastating consequences, and proper technique can significantly improve knot security, from the standpoint of a surgeon, proper knot tying technique should be considered important. It is worth noting that complications from insecure knots can be best understood through the so-called Swiss cheese model. In order for a knot to cause a complication, it must first be exposed to external tension. For example, in the carotid endarterectomy case study, when the patient was normotensive and calm, there was no evidence of bleeding. Only when he became agitated and his blood pressure escalated did he begin to bleed, because at that time the knot was exposed to more significant tension. Second, the knot must be less secure than the tissue is strong, because if the knot is more secure than the tissue is strong, the tissue will fail rather than the knot. And third, the external tension to which the knot is exposed must be greater than the security of the knot, because if a lower tension is applied, then the knot will not slip far enough to cause a problem. Only when all 3 of these conditions are met will knot failure result, and only when the knot is tied to a clinically important structure will this knot failure become apparent.